Excellent morning, distinguished participants. I want to recognize all the retired heads of service and permanent secretaries on this call, retired directors, distinguished guests, ladies and gentlemen. It's a pleasure to have you on this call this morning on webinar for retirees. This morning, we are going to be talking about cholera. As we know, it is no news, there is an outbreak of cholera in Nigeria. And as we know, it's a very contagious disease. It can be very deadly. It is waterborne. And we can get it from food for those of us who eat out. But the good news is that it is treatable. So we are going to hear it all this morning from our facilitator, Dr. Sukomi Muritala. Before we go on, let me just say the permanent secretary and the head of service are not available at this time, but the PS may join us later. So let's just go right into it as we look at the citation of our facilitator for today. I'm sure he's someone who does not need much introduction. He is the one who has been ensuring that we keep bringing different topics and have erudite scholars and great doctors who have been speaking unto us on this call. So Dr. Murita Lasukomi is an astute clinician and a general practitioner with growing interest in public health. He is an assistant director in Lagos State Ministry of Health, Directorate of Staff Health Services, a graduate of the prestigious University of Ibadan. His work experience spanned both in private and public sector. Dr. Muritala is married and a proud father of two beautiful children. On that note, we'll invite Dr. Muritala to go ahead with his presentation. Please unmute and go on with your presentation, sir.
Okay. Thank you very much. Thank you very much, ma, for the wonderful introduction. Thank you. And I say good morning to everybody, retired head of services, retired permanent secretaries, retired directors, and everybody present here on the Zoom call. I welcome everybody this morning. I'd like to say a very good morning to everybody once again. As Mrs. Dorodola has introduced, my name is Dr. Muritala, and this morning I'll be taking us through cholera. And as she has rightly said, if we've been listening to the news recently, we would agree with me that cholera has been something that has been on the news for a few weeks now. And unfortunately, I know Lagos State is usually known for very good news and different developments, positive developments. It is quite unfortunate that when when this outbreak of cholera started in Nigeria, Lagos State so far has recorded the highest number of cases. In the nation. So this morning, while we are going through cholera, we would be able to identify one or two reasons why Lagos State is the epicenter of this present outbreak, and then we would also be sharing tips on how to prevent it and also do a little bit of justice to the treatment. And like as Mrs. Drodala rightly said, cholera is it can be very life-threatening, but I believe that because a lot of people say cholera is this, cholera is that, a lot of people don't really know so much about it. Cholera can actually be quite mild for some people, and it can be life-threatening for others. So as we go ahead with this, as we go through this discussion this morning, we'll be able to tell the different types of cholera, the different types of presentations of cholera we have, how to prevent it, and then for people that have it, how to treat it as well. So join me as we go ahead with this presentation. So we'll be talking about cholera under this following topics. I will share a bit of the historical background of cholera. We'll talk about the introduction to cholera. We'll talk about the etiology, which is the causative agent of cholera. We'll talk a bit about the pathophysiology. Pathophysiology simply means how does the organism cause a disease in the humans. And we'll talk a little bit about the clinical presentation, how the symptoms of cholera. Then we'll talk about a little bit about the management, which I'm not going to really go into so much details into, and then we'll talk about the prevention of cholera as well. So let me start by saying cholera is a very, very ancient disease. As far back as the 460 BC, records of the Greek philosopher, a very popular Greek philosopher, he described by the name of Hippocrates. He has described an illness that was very similar in the presentation or in how cholera today presents. So this basically just shows us that cholera has been with us for the longest time. And then the first discovery or the actual discovery of the organism that causes cholera was credited to a German bacteriologist named Robert Koch, who independently identified the organism that causes cholera during an outbreak in Egypt in the year 1883. However, in the 19th century, not a lot was done about, he described the organism that causes cholera, but not a lot was known about how it actually spread from one person to the other, or the natural reservoir of the bacteria that causes cholera. Until the 19th century, when an English physician by the name of John Snow provided the first demonstration of how the transmission of cholera goes from one person to the other, from one person to another. And he did this during a recurrent outbreak of cholera in London in the year 1854. What he noticed was that everybody that went to a particular tap to get water would actually come down with this illness. And then he demonstrated that, okay, this can actually be reduced or stopped by removing the tap of the Broad Street pump. So the pump was on the Broad Street. He removed the pump handle, so nobody could go there to go and get water again. And miraculously, it felt miraculously then, but what we now know, it was a building block to what we now know as how cholera basically spread. After you remove the tap of the handle of the pump, the cases of cholera basically reduced in London, and then the outbreak subsequently died off naturally. So over the years, since it was first described, 7 cholera pandemics have occurred worldwide. So what I mean by pandemic is, so let me give an example of what a pandemic is. When COVID came, because it spread from one country to the other, and its spread was spreading fast, and then was able to move from one country to the other through different continents. That is what usually we call a pandemic. Unlike what an epidemic is, which is usually localized to a particular country or a particular state. So 7 cholera pandemics has been reported worldwide. And the first occurred between 1817 and 1823. And all the continents in the world have been affected by this cholera pandemic, with more than 150,000 deaths recorded in the year 1832 and 50,000 deaths recorded in 1866. So we know that this cholera, what we are talking about is actually a very, very serious case, and it's something that has a case fatality of almost 50%, which case fatality just simply means that for people that really come down with the severe form of cholera, the chances that they are going to succumb to the disease or die from the disease is almost as high as 50%. So we are currently experiencing the seventh pandemic of cholera, which is the first in the 20th century. It began in the year 1961, and by 1991, it has affected 5 different continents. It's originated from somewhere in Indonesia and has spread to a lot of countries and to a lot of continents as well. So it is important to note that cholera is not a major concern in very developed countries or industrialized nations for the past century. However, it is still a common condition in places in sub-Saharan Africa and sub-Saharan areas, and then the areas that are still, the countries that are still in the industrialized nations are not really so concerned about, except when people from all these developing countries who have been in contact with cholera travel to their country and then maybe spread it there. Otherwise, it is not something that usually would occur randomly. However, in Africa, sub-Saharan Africa, to be specific, local epidemics of cholera still, there was an outbreak in Zimbabwe, which is still ongoing now. It has actually become an endemic disease in some parts of Africa, including Zimbabwe, where reported cases of cholera still happen on a daily basis. There are a few factors that encourage the spread of that encourage the epidemic of cholera, which includes war, which is not something that we are familiar with in this part of the world, civil unrest and natural disaster, especially when food and water supplies become contaminated with the organism that causes cholera in people, crowded living areas and areas with poor sanitation. You all will agree with me that as much as Lagos is trying very hard to try to keep our environment clean and healthy, there's a lot of areas around us will still fall under this category of poor sanitation and a crowded living environment, especially in Lagos, where the population of the state is way more than what other states record due to the mass immigration of people from other states to Lagos for different reasons, most commonly economic reasons. So let me briefly introduce cholera to you. So cholera is an intestinal infection caused by a bacteria. So the organism that causes cholera is actually a bacteria. It is called Vibrio cholerae. Like I said, it was first described in 1883 by Robert Koch. And then the hallmark of the disease is profuse diarrhea. So we all know that a lot of people would say, okay, at some point or the other, they've experienced diarrhea to a different extent. However, with cholera, the kind of diarrhea that they have is usually it's usually a very watery diarrhea that usually continues for a long time. And if not quickly arrested or treated, person can actually die from that. So, like I said, cholera can be endemic. Endemic is that, like the example of Zimbabwe that I gave, that has been happening there on a daily basis for the past 10 years. That is an example of an endemic. So, for an epidemic, it simply means that it has not been happening routinely in that area. Suddenly, there's an outbreak of that disease in that particular area. While pandemic, it's something that spread between countries and between continents, and usually would have end up affecting a lot of countries all over the world. So cholera can can be endemic, can be epidemic, or can happen as a pandemic, depending on how fast how fast it spread from people. And despite all the major advances in research, cholera still remains a very, very important medical ward because of the case fatality rate that I mentioned, that is almost 50%. However, like I said in my opening, the disease severity ranges from asymptomatic. Asymptomatic simply means that even when somebody comes in contact with the organism causing cholera, which is the Vibrio cholerae, the person can go on to not have any symptom at all. They can be a carrier of the disease without developing any symptom at all. However, some people would develop some symptoms which might be mild to moderate. They might be stooling, vomiting, but it might not be life-threatening. While others, unfortunately, would have a life-threatening form of the disease. The most feared form of cholera is the severe cholera, because it can cause severe dehydration within a very short period of time. leading to death, often within a few hours of onset of the disease. And the transmission of cholera is the fecal-oral route. So what do we mean by fecal-oral route? Basically, it means that it can be ingested through the mouth, and then the organism can be passed out through the anus. So contact with contaminated feces, contaminated water that the feces have gotten into in contact with, can be a source of transmission, or can be a source of agent of transmission for the organism that causes cholera. Prevention, however, still remains the best form of the intervention for cholera. So let's talk a little bit about the etiology of cholera. So the etiology basically means the causative agent. And the causative agent, like I mentioned, is a bacterium called Vibrio cholerae. It is, if you look at it under a microscope, if we can all see my slides, where my mouse is pointing to is a picture, an electron microscope picture of what the organism looks like under the microscope. So it's a comma-shaped gram-negative anaerobic bacillus that varies in size from 1 to 3 micrometer in length. And it's a very, very small organism, because that's why a lot of them cannot be seen with our naked eyes, except with the aid of a microscope. So for cholera now, in about 200 types of cholera has been identified since it was first described. So there are 200 different types of this organism, each having some different distinguishing factors in them. However, the subtypes 01 and 0139 are the most principal ones that have been associated with epidemic cholera. So most times when an epidemic of cholera happens in any part of the world, usually it is one of these two that are usually the commonest cause of those epidemic in those areas. So the natural habitat of cholera is naturally a marine organism. It's usually with a preference for salt water. The primary habitat is the marine ecosystem, where it lives with in association with some organisms, other called planktons. And so, like I said earlier, so only two known reservoirs for the bacteria that causes cholera: humans and water bodies. If we eliminate these two, cholera would also cease to affect anybody. But then, if we eliminate humans, that means there's no point in doing that at all. So humans are the only known organisms that actually carry cholera, or that it causes diseases to them. And water, like I said, is a natural habitat of this organism. So the cholera bacterium has been really isolated from animals, and animals do not play an active role in the transmission of the disease at all. So primary infection is usually incidental through the ingestion of maybe contaminated water or food by humans, and then it spreads on from there. It gets into the intestine, and the person passes it out through the feces, and if the feces get in contact with other water bodies or contaminate food and water that other people are going to drink, that's how people can get the infection from other people who are actually suffering from it. So like I said, secondary transmission occurs through the fecal-oral spread of the organism, through person-to-person contact, or through contaminated water and food. So what we mean by person-to-person contact, this is actually not something that is very, very common, because thanks to recent advances or to a lot of things that we do now, especially hand washing. Most people, when they use the toilet, they will usually wash their hands and mouth. So most of the time, it is easy to, if we use a soap or an alcohol-based sanitizer on our hand, most of the time we'll actually take care of this kind of bacteria. So the person spread is not something that is very, very significant, except of course when the person that is infected feces or other body fluids get in contact with maybe our food or drinks, or it gets contaminated, and those things get contaminated, and when we ingest it, that's how it usually would occur. So secondary spread commonly occurs in households, but it can also occur in clinic and hospitals where patients with cholera are being treated. Infection rates predictably are highest in communities in which water is not potable. So what we mean by potable is water is just safe drinking water that are not safe for drinking. So we know a lot of people, usually maybe in some rural areas, they get their water from the streams, from rivers and the rest of them, where other people might also go to defecate in. And so that is why the highest spread of cholera has been documented in rural environments. And then we take us now when it was first reported, and then studies and research that has been done, that has gone into how it started, has basically showed us that it started from the consumption of unhygienic drinks that was manufactured by some people. So it simply means that whatever water those people have been using to produce their tiger nut or whatever drinks that might have other people might have gotten in contact with must have been contaminated by the cholera by the bacteria from somebody who has been previously infected. So in communities where the hygiene standards are very high, the transmission or the spread of cholera is very, very low. And the opposite case, communities where the hygiene standards are quite low. So we'll talk a little bit about the epidemiology. So epidemiology basically just means we are looking at from what has this cholera, what has the spread been like in the past few years. So according to WHO, the number of cases actually surged in 2005. And then between 2005 to 2008, 178,000 to 237 cases were reported worldwide. Of this, about 4,000 to 6,300 deaths occurred from cholera. However, I would like to say that these numbers might not be the most accurate numbers because a lot of all these cases and a lot of cholera cases might have gone undiagnosed, especially in most rural areas. And then for areas that, because the diagnosis of cholera requires a high clinical index, a high clinical suspicion, index of suspicion for cases. So if it's not something that, because it's not something that routinely occurs, if a clinician is seeing a patient that has profuse diarrhea, other causes of such condition might have occurred to the physician before he or she would consider cholera. But unless when there's an epidemic or a local outbreak somewhere, then out of for every person presenting with any diarrhea disease, would consider cholera as one of the causes. So the number that we are seeing that has been reported might not actually be the actual number. There might be much more than this, especially in rural areas in sub-Saharan Africa. So in Nigeria, since it was first epidemic of cholera was reported in the year 1972. Since then, intermittent outbreaks have been occurring in different parts of the country. Into the later part of 2010 was marked with severe outbreak, which started from the northern part of the country, which quickly spread to other part of the country, and it involved approximately about 3,000 cases were reported within that period, and then about 781 deaths was also accredited to cholera. Since then, sporadic cases have also been reported. Sporadic cases just simply means that different spreads of small spreads of cholera have been reported in different areas, which has not gone beyond control. And so, with the present outbreak that we are experiencing in Nigeria, according to the NCDC, a total of 576 cases have been reported thus far. However, it is important to note that Lagos accounts for about 533 of the reported cases. And just last week, 113 cases were reported in different parts of the country. However, out of these 113 cases, 104 of the new cases was credited to Lagos alone. Other states that have reported cases of cholera includes Ogun State with about 19 cases, Rivers State with about 9 cases, Katsina with 8, Oyo and Abia State with 2 cases each, and then including Bayelsa, which has reported about just 2 cases, and then Sokoto with just 1 case. We can see from what they are saying that, okay, Lagos is the epicenter of this outbreak of cholera, and then all hands have to be on deck for us to be able to control and ensure that it doesn't go out of hand in Lagos. So we talk a little bit about the pathophysiology, which is how the organism spreads from people to people and how it causes infections in them. So like I said earlier, the mode of transmission is the immediate source of infection are the stool and the vomit of people that have cholera, already have cholera. And people, like I mentioned earlier, some people might have cholera, might have the organisms in them, but might not be showing any symptoms of the disease. Those are the kind of people that we call the carriers of cholera. However, it is not what it should say that cholera and the carriers of cholera, they are not something that usually stay in them for a long time. Unlike people who are carriers of things like, say, Salmonella typhi, which is the causative organism of typhoid, which causes a very similar illness to cholera as well. For carriers of those ones, usually the organism usually stays longer in their system. But for cholera, the organism doesn't stay so long in the carriers. Then within 2 to 3 weeks, they usually would have shed off all the bacteria, and then they would be free of the organism, and then effectively they will not be able to infect or transmit the disease to other people. So the infectious dose of cholera of the organism that is required to cause clinical disease varies from the mode of administration or the mode in which it gets into the body. So if it is ingested in water, the infectious organism and the infection is usually larger. And I would say I would come back a little bit to that. So there are some factors that would encourage the infectivity of this organism in the body. It has been documented scientifically that people with blood group O are more susceptible to the organism. So in this kind of people, so if they come in contact with contaminated water or food items that carries a very small amount of the bacteria, they can end up developing active disease because of their genotype. Also, for people who have low gastric acid, for people especially who are non-ulcer patients who are on things like proton pump inhibitors or antacids, or they who have had some form of gastric surgery that's to reduce the amount of acid produced in their stomach. Some of these people are more susceptible to this organism. However, it doesn't mean that it cannot affect other people. It just means that these people are more at risk of developing the active or the clinical disease called cholera. So the incubation period, which simply means when the organism gets into the body, or when it gets into the body to when the person actually starts showing clinical symptoms of the disease, is usually between a few hours of the ingestion of the bacteria to about 5 days. But commonly, onset of symptoms is usually seen between 24 to 48 hours of coming in contact with the organism. When the organism gets into the mouth, it travels from there through the stomach and in the stomach, however, something I didn't mention earlier, when I mentioned people that have ulcer, it is the organism is not resistant to the gastric acid. So the gastric acid in our stomach actually plays a vital role in actually protecting our body against this kind of organism. Because when it comes in contact with this organism, the acid actually the bacteria, and that is why people who have ulcer or who are taking medication to reduce the acidity in their stomach are more susceptible to the cholera. So when it moves from the stomach, let me quickly mention, if we want to actually be infected with cholera, you actually need about 1 million organisms be present in whatever we are taking in. The amount of contaminants in the water or the food that we are taking has to be a lot. So for water, it has to be maybe about 1 million to about 5 million of the organism. But like I said, these organisms are very, very small. So we're talking about the milk organism, something that we cannot even recognize. And it's something that can actually occur without us even knowing about it. But it's just important to know that part. So when it moves from the stomach, it moves to the small intestine, where the organism actually become domiciled, they stay in the small intestine, multiply in folds. But as they're multiplying, they also produce something, they produce a toxin that is called is an enterotoxin. Enterotoxin simply means a toxin that affects the intestine. And the toxin acts locally in the intestine. It doesn't actually leave the intestine to go into the bloodstream. It actually acts locally in the intestine. How it does that is it attaches to some receptors in the intestinal wall, which causes a reverse of what normally happens in the intestine. So normally what happens in the intestine when we eat and drink our food is that absorption takes place in all those areas. But whenever this toxin or when this bacteria is present in the small intestine and the enterotoxin is produced, what it causes is a reversal of that process. So rather than water and other items being absorbed into the system, what happens is that there's a reversal of that system, and then the water and everything comes back, especially water, the fluid and the electrolytes in the body, comes back into the lumen of the intestine. A lot of secretion of fluid electrolyte intestine. This usually would overwhelm the absorptive capacity of the large intestine, which the enterotoxin majorly affects the small intestine. It doesn't affect the large intestine. However, because of the amount of fluid that is coming from the bloodstream back into the intestine, it causes so much that the large intestine cannot absorb a lot of this, and then this is what usually would result in the very watery diarrhea that is usually known for. And so the large volume of fluid produced in the upper intestine, in the small intestine, overwhelms, like I've said, overwhelms the absorptive capacity of the lower bowel, resulting in the very severe diarrhea associated with cholera. So usually, the symptoms of cholera, like I said, the incubation period between a few hours to about 5 days. Like I mentioned earlier also, most people will within 24, 48 hours. So the body onset mainly what we can continuous and growing up or when we're put the cholera as a person student they are from this and it's so much that care is hours. The person can actually lose the very effective blood in and this can cause very severe dehydration, which can lead to other causes, what's it called, lead to death as well. So diarrhea of cholera is a very watery diarrhea that often it contains some form of whitish material, which is usually from the mucus and the mucus and some cellular linings of the intestines. Because all of these things are as the influx of the water comes into the sphincter, it sheds some of these things as well. So they usually will come together with the two, and then that's what gives the name to the characteristic appearance of the cholera stool, which is usually known as a rice water stool diarrhea. And it has been reported that it oftentimes smells fishy. So the volume of diarrhea, like I've mentioned, can be very, very enormous in cholera. And then the high level of it can be as high as 250 mils per kg. That is about 250 mils is about half of a sachet of half of the sachet water that people usually would consume. So over a period of 24 hours, a 70 kg adult can actually lose between 10 to 18 hours of fluid. When this happens, because our body is 70% of water, when this happens, which can be very, very dangerous for everybody, for anybody that is suffering from cholera. So the patient also can experience accompanying abdominal pain, which usually as a result of the distension of the part of the small intestine due to the large volume of the fluid that is coming into the intestine. So fever is not a very typical symptom of cholera. It can be present, however, it's not a typical symptom. So if somebody is vomiting and is stooling and the person doesn't have fever, it doesn't rule out. The person doesn't have fever, it doesn't rule out cholera. And if the person has fever as well too, it doesn't actually rule out cholera. We are just simply saying that fever is a typical symptom of cholera. So if you can see the pictures that I have up here, so just talking about some of the symptoms of diarrhea, of cholera. So we have profuse diarrhea, we have vomiting, and we have dehydration, which results usually from the diarrhea and the vomiting, and then abdominal pain, which I just explained, and is due to the distension of the abdominal, the part of the small intestine that is due to the amount of fluid that's coming into them. Also, people suffering from cholera can also go ahead to go and develop hypoglycemia. This is usually due to the unable to eat because they are quite sick and they are tired, they are weak, and because of a lot of the biochemical changes in the body and then the depletion of the glycogen store in the body as well too, a lot of them would end up coming down with hypoglycemia. Hypoglycemia simply means low blood sugar, which usually would define as a random blood sugar of less than 40 milligram per dl. When this happens, when people develop hypoglycemia, it further worsens the outcome of cholera because this alone can actually cause death on its own. I mean, the hypoglycemia. So also because of the stooling and the vomiting as well too, they usually will come down, complain about weakness, and a lot of times there are other symptoms that they usually will present with, such as tachycardia, which simply means the rapid heartbeat. This happens because the amount of the tachycardia for most people depends on the amount of fluid that has been lost. Also, so most of the symptoms of cholera that I'm going to say now are due to the dehydration or due to the effect of the stooling and the vomiting that actually occurs with cholera. So most of them are just a result of that in the body. They are usually a result of the different biochemical changes that would occur in the body. So they include muscle cramps, which is usually affects the leg, restlessness and irritability. So a lot of people who have cholera, especially the severe form of cholera, would usually be very restless and usually easily irritable. Also, unusual sleepiness. So we find that a lot of them usually present with some form of somnolence. They are usually very sleepy because they are weak, they are tired, their blood sugar is low, they are losing a lot of weight, and so they don't have enough strength to actually do their usual activities that they usually do. So same thing that happens with easy fatigability. Easy fatigability just simply means they get tired easily. Also, they can also present with headache and rapid breathing. So the rapid breathing is as a result of something called a metabolic acidosis that usually would happen when people lose a lot of bicarbonate in the amount in the fluid that they are either passing out as stool or with the vomiting. When we lose a lot of bicarbonate, the pH of the blood basically rises, and then the body tries to compensate for it by actually expelling more. The body tries to compensate by it, but usually by shallow rapid breathing is some of the way that the body compensates for the acidosis. Also, because of the frequent stooling and the diarrhea, pain around the anus, and also because of the amount of fluid that's being lost from the body doesn't have enough fluid or enough fluid in the body to actually process for urination. So they usually come down with very low urine output or no urine at all in something that we call oliguria. And also because of all of these things that are happening concomitantly in the body, and then because of also the hypoglycemia that can also occur, some people can actually end up having seizures or something, or even present in coma. And for the seizure is usually more common in children. The seizure and the coma is usually more common in children, or with people that have lost a lot of their body fluid due to the diarrhea. So I mentioned earlier that the characteristic appearance of the stool in cholera is called the rice water appearance. If you can look at this picture that we have, that is being projected, so we can look at the picture, the stool. Yeah, this is a stool sample from somebody who actually has cholera. It appears as if we wash, or for some people that parboil rice, if you parboil rice for maybe a few minutes and then you rinse out the water, this is what the color of the water usually look like. So that is why they usually refer to this rice water stool. And then if you look at the other picture here with the sample in the bowl, you can see that it has some flecks of some whitish particles in it, which I mentioned earlier, just some part of the mucus from the intestine, and then some of the gastrointestinal, the cells of the intestinal lining that's been shed during the stooling. And then another picture here just shows another sample that is in a cup that you can see that it looks thoroughly white, and it looks like if one does not even know that this is stool, one can actually mistake it for maybe a water that has been from the boiling of rice. So we've talked about the clinical, and we've talked about the symptoms of cholera. However, let's just quickly mention a bit of when a person presents in the hospital, what are the things that we are looking out for as clinicians? So the clinical signs and symptoms of cholera usually parallel or mirrors the level of fluid that the person has lost, or the volume contraction in the body. And so the amount of fluid loss and the corresponding clinical signs of cholera is usually as follows. So for somebody that has lost about 3 to 5% of their normal body weight in the so 3 to 5% of body weight loss in sense of the fluid that has been lost, the quantification of the fluid that has been lost in the body. Usually for those kind of people, they usually have a very mild disease. And then what usually they present it with is just usually excessive thirst because they are usually losing water as they go on. So they're usually very thirsty. They want to drink more water, to replace the amount of fluid that they are losing from the stooling and the vomiting. So that is usually the first stage. In such people, when we move down to the treatment, I'll mention how we usually will treat such people. The second stage is usually for people that have lost about 5 to 8% of their normal body weight in terms of the fluid loss. And such people usually will present clinically with postural hypotension. What I mean by postural hypotension is, so when somebody is lying flat on a very flat they might not have any history of dizziness, no history of tachycardia, which I mentioned is a rapid heartbeat. But once they stand up upright or they are sitting up in bed, they usually start feeling very dizzy or they start feeling like fainting. This is usually due to reduced blood pressure in them, which is occasioned by the loss of fluid in their body, and which I mentioned here to be about 5 to 8% of the normal body weight of such a person. So, and that also will result in tachycardia, which is a rapid heartbeat, weakness for such people, and easy fatigability. Their mouth becomes very, very dry, and it feels like if their mouth is patchy, and they feel as if their lips is sticking together. They are also present with things like restlessness and irritability. For people who have actually lost more than 10% of their normal body weight in terms of body fluid loss, they usually present with something which I mentioned earlier, called oliguria, which means that their body is no longer producing, that their kidneys is no longer producing urine again, because all the effective circulatory volume of in the body has been so much depleted that blood and every other thing will have been diverted to the very, very important organs in the body, which is most notably the brain, and which is usually about the last the organ to go in such people. So for such people, they will also present with sunken eyes. It feels as if their eyes is very deep in their socket because of the amount of fluid that they have lost, or their tissue has devitalized, so they have very sunken eyes. And then they usually have, in children, there's something called the fontanelles. I don't know what it's called in Yoruba. I think the part of their head, usually in babies, usually around there, is usually a very indicator, it's a very important indicator for us as clinicians to assess the degree of dehydration in children. So that also becomes very sunken, becomes very depressed in them. They can have a weak, thready, or absent peripheral pulse. So usually, I'm sure a lot of us would have been familiar with this. Maybe you go to the hospital and then you see maybe the doctor putting their hand on your hand like this, trying to feel your pulse. When a lot of dehydration happens in the body, that pulse that they usually feel, we feel it as a form of beat against our finger when we feel for this in patients. It beats rhythmically against our hand, and so we feel that on our hand. However, with somebody that has lost about 10% of their body fluid, this becomes very weak in them. The pulse becomes very weak or very thready. Very thready means that it's just a very slight palpation or palpitation that we feel against our hand when we feel it. Or the pulse can actually be absent. When this happens, it simply means that most of the circulating blood volume has been diverted to more vital organs in the body. And so they can also have something called a wrinkled skin appearance, which is called a washerman or washerwoman syndrome. It simply just means that their hands or the skin on their body becomes very, very dry, such that when you peel or when you pull up the hand, can everybody see how my skin simply returns back when I pull it up and it goes back immediately. However, in such people, when you pull it up, it remains there for a few seconds to minutes before it goes back to the way it's supposed to be. And this is usually due to the dehydration, the amount of dehydration that has happened to them. Also, they can have altered consciousness. Some of them can become, their sensation and then the consciousness can be altered in different ways, and then ultimately lead to something like coma in them. Like I mentioned earlier, one of the commonest one of the commonest complications or symptoms that we are also on the lookout for is hypoglycemia. It's one of the common lethal complications of cholera, especially in children. And usually, sometimes when we correct or when we are trying to treat, we have to put all of this into consideration when we are also treating. So to be able to correct the hypoglycemia in them while we are correcting the dehydration as well. So the hypoglycemia, like I mentioned earlier, usually will result from diminished food intake during the acute phase of the illness, the depletion of glycogen stored in the body, and the defective gluconeogenesis secondary to the insufficient sources of gluconogenic substrates in both the fatty and the muscle tissues of the body. Metabolic acidosis, which I've mentioned earlier, results from the loss of bicarbonate in the stool and a retention of lactic acid from the reduced tissue perfusion, which usually results from the reduced blood flow to such tissues. There's something else that is very, very important. They are called the biochemical markers of cholera or biochemical markers of dehydration. It is something called hypokalemia. Hypokalemia simply means reduced potassium level in the body. Potassium plays a very, very important role in the body, especially in the heart, where it helps with the contraction and the relaxation of the heart. When it becomes very reduced in the body, it can actually lead to a cardiac arrest in the body. And then potassium is usually lost in patients who have cholera, especially through vomiting, and also can be lost in through the stooling as well, but most importantly through the vomiting. Like I mentioned earlier, severe dehydration can result in shock, meaning that the perfusion, that means the blood flow to vital organs such as the liver, the kidneys, the intestines, the brain, can be so much reduced that the body cannot cope at all with the amounts of the circulation of the perfusion to such tissues, and then the body goes into a state of shock. And then it can also result in something called acute renal failure, and also can present with heart failure in such patients. If untreated, especially with people that have severe dehydration, it can rapidly lead to shock and death within a few hours of the onset of the cholera, of the onset of the symptoms of cholera, usually between 4 to 8 hours. People that have been known to actually die within 4 to 8 hours of from when they start from when the first liquid, from when they first pass the watery stool. However, for most people that usually would die from cholera, usually would happen within 18 hours to a few days if they are untreated or undertreated. There's a very, very severe form of cholera that it's not something that is usually commonly seen again in clinical practice because of the advances in treatment and the advance in especially the antibiotic therapy, and then the rapid onset of treatment for such people. However, it is just important to also note that there's something called cholera Zika. So it is an old term describing a very rare and severe form of cholera that can happen during an epidemic of cholera. It usually manifests as something called ileus. Ileus just means that the part of the intestine becomes paralyzed. So now I mentioned earlier that hypokalemia is reduced or loss of potassium in the body. Now, aside from the heart, the potassium plays a very key role in contraction of other muscles as well, too, including the muscles in the walls of the intestine, the small and the large intestine. When there's a lot of loss of this potassium in the body, it can lead to something called ileus, paralytic ileus, which basically means the intestine become paralyzed and they cannot move the stool, or they cannot move the content of the stool across from one part of the body, from one part of the intestine to the other, to eventually move it to the rectum, where the person would eventually pass the stool. It simply means that the intestine becomes static. And then because of the amount of the mass outpouring of fluid and electrolytes into the intestine becomes very, very dilated. And that is usually what, because it doesn't usually present, because the intestine is paralyzed, and then it presents with distension or abdominal swelling. A lot of this is not usually recognized by clinicians when it happens. And like I said, it doesn't usually present with stooling for such people, so that it might be easily misdiagnosed as something else. And then for such people, death usually would happen within the first few hours of the onset of this kind of symptom. So it's not a very common presentation. However, it's a very, very rare form of cholera. But however, it is something that we ought to mention because we are currently undergoing a local outbreak in Nigeria of cholera as well. So with cholera Zika, the mortality is very high. The deaths usually result from the toxemia. This basically means the accumulation of toxins in the body, even before the onset of diarrhea and vomiting, which, like I said, because of the paralysis of the intestine, might not even be present in such people. So the mortality is very, very high. And because of the unusual presentation of this kind of form of cholera, there's a failure to recognize the condition as a form of cholera, and then treatment for it might not be easily instituted. Okay. So moving on to making a diagnosis of cholera. Let me state here that diagnosing cholera is, especially during a local outbreak like this, is usually a clinical diagnosis. So we know that, okay, there's a local outbreak of cholera in Nigeria, and we know that we have a lot of cases in Lagos. So if, as a clinician, somebody goes to the hospital and then the person is complaining about severe diarrhea, vomiting, abdominal pain, weakness, and all of those things, even if it doesn't present with weakness and all of those things, but severe diarrhea and vomiting, one of the differential diagnoses as a clinician that would also want to look at first would be to rule out cholera. And then one of the ways that we can actually quickly make a diagnosis of this clinically is to simply ask the person, what does your stool looks like? So like I mentioned earlier, there's a characteristic appearance of the kind of stool in diarrhea, and then this is the rice water stool appearance. Once somebody comes to the hospital or presents even at home with this kind of stool presentation, it is very, very important that the person needs to quickly go to the nearest hospital and then ensure that the person gets treatment immediately. And then usually the treatment of cholera is actually not very, very difficult. But we'll talk about that briefly. Also, it is important to note that the diagnosis or to make a diagnosis of cholera is not something that we can do in the regular laboratories that we have in our hospitals. So it is something that has to, the stool samples or the samples of the vomit has to be taken to a public health laboratory. And we're lucky in Lagos that we have one in IDH Yaba, where samples of biological importance can actually be taken to, and then such diagnosis can easily be made. So the only way to actually make a definitive diagnosis of cholera is to isolate and identify the causative agent, which is the Vibrio cholerae, in any of these contaminants, either the stool or the vomitus of the person that is suffering from it. And so they do this by usually the dark field or phase contrast microscopy. Like I said, it's not something that should be done in a routine laboratory because of the risks of contamination and the risks of spreading those infection to other people as well too. So there are some pictures here. If we look at it, when they look at what's it called, the under the microscope, and then they're able to identify the organism. This is what the organism usually look like. I mentioned earlier, it's a comma-shaped organism, has a bit of a tail which helps it to move along in the intestine, and it has some form of hooks which are not very, very obvious in this. These are the hooks that it usually would use to attach itself to the walls of the intestine. Another way that which they can make a diagnosis of this is to do a stool culture on something called this thiosulfate citrate bile salt sucrose agar plates. It's for short we call it the TCBS agar plates. So usually what we do is okay, we'll put some of the samples from the stool on this kind of agar. The agar is just like a plate that's been formulated to encourage the growth of the organism so that we can actually grow the organism and then subject it to different tests to know which antibiotics is most effective in killing it. Usually when it grows in this kind of agar, this is what it looks like. It looks like this golden yellow round colonies. So what we see here, these round stains, are colonies of the bacteria that are growing on the agar plate. So once this is done and we are able to make and it comes this appearance of cold, we can actually say, oh, this person definitely has cholera. Other ways to make diagnosis or other tests that can be done include the polymerase chain reaction. And WHO has actually come up with a rapid test kit, which is called the Crystal VC Dipstick for cholera. It's usually deployed in periods of epidemic to quickly test people who we suspect might have cholera. However, when people test positive to this rapid test kit, because it is not specific and it is not sensitive alone to cholera, we must, however, still try as much as possible to confirm our diagnosis with either the microscopy or the stool culture or the polymerase chain reaction. So the last test is something that can be easily deployed in the field to quickly test or to quickly raise alarm about the possible advent or the possible occurrence of a local epidemic or an endemic epidemic in a particular area. However, like I said, whatever we do with this, we must actually still go back and confirm the diagnosis with all the other tests that I've mentioned that can be carried out in the public health laboratories. So let's talk about the treatment of cholera. If we look at my very first statement here, it says cholera is an easily treatable disease. I'm sure a lot of people would say, "Oh, is that right?" Yes, that is very, very right. Cholera is actually very, very easily treatable because the organism itself is not what is causing the problem. It is because of the enterotoxin I mentioned earlier, which causes a lot of influx of fluid from the body into the intestine, and which eventually leads to the diarrhea. So basically, the mainstay of treatment, the priority in the treatment of cholera is to rehydrate people that have lost a lot of fluid due to the stooling and vomiting. Now, the rehydration is usually in two phases. We have the rehydration phases. The rehydration phase is basically just to replace what the person has lost. So the person has been stooling for maybe a few hours or a few minutes. The person might have lost maybe 3 to 5 liters of fluid already. So immediately we want to rehydrate the person and replace such fluid that the person has already lost. And then the second phase is the maintenance phase, which basically means while the person is still within our care, we are maintaining the ongoing losses that the person might still be experiencing. So in addition to restoring the fluid that the person has lost, the person might still be stooling and vomiting while they are sitting in the hospital. So the maintenance phase is just basically to replace that ongoing loss for them. And usually we want to do this, especially the rehydration phase, within 4 hours of the onset of symptoms for these people. And when we are able to do that, usually the prognosis is usually much, much more better for those people. So the majority of people can actually, however, be treated successfully with the prompt administration of oral rehydration solution, which is our common ORS solution, the one in sachet that we usually put in 1 liter of Eva water, or in 1 liter of very clean water, and then we're able to drink. So, however, for people that can be treated with ORS, it simply means that people that have very mild disease or very moderate disease, not the people that have the very severe diseases. However, we know that in some rural areas where the access to healthcare is not very, very optimal, ORS can actually still be used to treat the very severe cases. But for such people, adult patients may require up to 6 liters of ORS to actually treat the moderate dehydration, or even sometimes the moderately severe dehydration that can occur with such patients on just the first day alone. And then as much as possible, we'll encourage everybody that, okay, they should try as much as possible to get into the hospital, because the best form of treatment for people who are severely dehydrated, there are also people at risk of developing shock, is the rapid administration of intravenous fluid. So IV intravenous fluid, which is the drips that we usually will give in the hospital, is the mainstay of treatment for people who have moderate to severe form of cholera. The choice of the drip that we usually get is something called lactated ringer solution. In the absence of ringer solution, people can actually now use things like normal saline. But lactated ringer solution is the ideal fluid of choice for the treatment or for the replenishment of the fluid and the electrolytes, especially things like sodium, potassium that the person is losing through the stooling and the vomiting. Also these patients, ones that have severe dehydration, also we give preference to them to also give appropriate antibiotics treatment to them to diminish the duration of the diarrhea and reduce the volume of rehydration fluid needed for them, and to shorten the amount and duration of the bacteria that they are excreted in their stool, which also makes them less infectious to other people. So we'll talk about, I'll mention some of the antibiotics that are of choice in treating cholera later on. So yeah, as a rule, all patients that are able to start eating once we started resuscitating them, or they are stable enough to start eating food through their mouth, is usually would say, okay, start eating safely prepared, regular local food as soon as they can safely do so. So for people that were vomiting before and they stop vomiting, and then they feel they can tolerate oral fluid or oral feeding, we usually say, okay, you can go ahead and start taking that as soon as possible. Also, for children or infants who are sufferers of cholera, we usually would promote or encourage breastfeeding for them, because breastfeeding alone itself has some protective factors that also help such babies in quickly overcoming cholera. And those who don't even have cholera, they have some protective factors in them that can actually help them to prevent or reduce the risk of them coming down with cholera as well too. This is why we always encourage breastfeeding with all of our breastfeeding or nursing mothers. So like I mentioned earlier, I said the amount of dehydration for people is what would determine the kind of treatment that we usually would institute for them. I will not go into details with this particular slide. It's just good to note that for people who have mild or no dehydration at all, we can treat them with the oral rehydration therapy, which is the ORS. Some people that have some mild to moderate form of dehydration. Also, the ORS can still be used for such people, especially within the first 4 hours of the onset of symptoms. However, if it has gone beyond the first 4 hours, because of the amount of fluid that they will have lost within that first 4 hours, it is ideal to now treat them the way we would treat anybody that has severe dehydration, which I mentioned earlier, is to do IV infusion or IV drips of Ringer's lactate in the hospital. And I mentioned earlier, if Ringer's lactate is not available in the hospital, normal saline can also be used to quickly hydrate these people. So all those the other ones that we have is just the WHO guideline for based on the amounts of based on the amount of fluid that they've lost, the age and the weight of the patient. So I will not go into this. These are basically for doctors in the hospital who actually treat cases of dehydration. So still on the treatment of cholera, zinc, I'm sure we are all very familiar with zinc. It's something that's been promoted and encouraged in the recent times as a treatment or as an adjunct to the treatment of diarrhea, not just due to cholera, but every other form of diarrhea, because that's shown that it can help to reduce the duration of the diarrhea and also prevent further episode of other causes of acute watery diarrhea. So zinc is an important adjunct to the treatment of cholera as well too. Mass administration of antibiotics is, however, not recommended as it has no proven effect on the spread of cholera and may contribute to antimicrobial resistance. What do I mean by this? We know that, let's take, for example, when COVID happened now, and then some people came out to say some type of antibiotics can reduce or can help manage COVID. I remember a particular antibiotic that was mentioned then was azithromycin. I know that even the price of azithromycin shot up in most pharmacies because the demand for it went very high. Because a lot of people feel when I take the antibiotics, they can actually prevent them from coming down with COVID. Same thing with cholera. Some people might feel like taking antibiotics can actually help them prevent cholera. It is not so. It has not shown that mass administration of antibiotics, it doesn't show any proven effect on the spread or even the effectiveness of the cholera. And then, like I said, it might contribute to antimicrobial resistance, which is something that is becoming a public health matter now, a very, very significant issue, because a lot of the bacteria that we have now are becoming resistant to the different antibiotics that we have in circulation, simply because a lot of people have abused these antibiotics so much that even with the work that these antibiotics are supposed to do, the organism that they are supposed to treat or to kill off have become so exposed to these antibiotics, and then they've developed this bacteria that have developed some form of defense mechanism against these antibiotics, such that the antibiotics are no longer effective towards them. So this is another thing that we try to avoid by not giving mass administration of antibiotics for people or for people to prevent cholera. Okay, so I mentioned the first point earlier. So the antibiotics of choice, usually that would give to people maybe usually with moderate to severe form of cholera, includes doxycycline, tetracycline, septrin, erythromycin in pregnant women, because doxycycline, tetracycline is not safe in pregnant women. It actually can cause some form of damage to the babies that they carry. So we usually will not use doxycycline or tetracycline for such women. So we'll go with erythromycin for them. Ciprofloxacin, which is another common antibiotic that is available, can also be used to treat cholera. However, it is not indicated in the treatment of children because it is actually very toxic to children, especially to the hearing. It can actually lead to hearing loss in children, it can lead to deafness in children. Amoxicillin is another form of antibiotics that can be used to treat cholera. From what we've said so far, we can all see that all the antibiotics that I've mentioned is something that we at some point must have heard or have been familiar with, especially things like doxycycline, tetracycline, and even the common septrin that is commonly used everywhere. So that's why we said the treatment of cholera is, however, not difficult at all. However, recognizing that this person might actually be suffering from cholera and quickly instituting treatment to mitigate against the loss of fluid in such people is the most important clinical index that I can actually encourage or that can actually foster positive prognosis in such people. So we talk about a little bit about the prevention and the control of cholera. And like I mentioned earlier when we started this discussion, I said prevention is still the best form of treatment for cholera, because if it is prevented, it means that we not get it, and if it is not gotten, it means that every other thing that can happen when people have cholera can actually be prevented. So we can prevent cholera through these following measures: drinking and using safe water or consuming safe water, which we can do either through boiling our water or through the consumption of treated water or through the consumption of bottled water. However, we must be very careful when we're saying we're taking things like sachet water or even bottled water, because in the news recently, I know some people were arrested for counterfeiting bottled water. And we don't know where they got this kind of water from. They just put them back in some bottles and then repackage it for. So if at all we want to use bottled water or sachet water, please let us go with brands that are well recognized, the companies are well recognized for safety. Also, practicing good sanitation and good hygiene. So our sanitation basically, one of the most important ways of practicing good sanitation and hygiene is our hand washing, which it is still it's an important tool in public health, in mitigating or reducing the spread of a lot of diseases. COVID, I remember during COVID as well too, hand washing was one of the major things that we were talking about, including the use of face mask. So hand washing still remains one of the very pivotal things that we can do on our own to reduce the spread of cholera. And hand washing with soap and clean water as well too. So as much as possible, when we want to wash our hands, especially when leaving the toilet or after urinating or after defecating, we must, as much as possible, try to encourage others and ourselves, our households, our co-workers, to encourage them to wash their hands with soap and clean water. However, I know that in some areas, maybe soap might not be readily available. If soap is not available, they can wash their hands with running water, clean running tap water, and then use alcohol-based sanitizers to also clean their hands or to actually sanitize their hand. And when we are using this, it's not to put a small amount of sanitizer on our hand and then try to minimize the use or economize the use of sanitizers. We must use a sufficient amount that it actually covers all parts of our hands, including under our nails as well, because these are part of the body that such organisms can easily hide under. So sanitizers and hand washing, they are very key points in key activities that can actually help to reduce the spread of cholera in our society. Also, properly cooking our food and eating it while it's still hot. So properly cooking food is simply, especially our vegetables, our tubers and the rest of them, because the cholera bacteria can also contaminate the soil in which this food have been grown. Maybe because of the contaminated water that might have been used to actually water those organisms, water those food while they are growing it in the farms. They can actually contaminate such food items. So especially our vegetables, I know that a lot of people sometimes will not cook our vegetables properly because we are trying to, as much as possible, to preserve some of the nutrients in them. What we can actually do is, before we cook our vegetables, we can thoroughly wash them before cooking, and then ensure that we cook for at least the best amount of time to actually kill off any form of organism that might be on them. It's not just cholera alone, there are a whole lot of other organisms that can actually be on such food items. And then studies have shown that properly boiling food or cooking, so some of the food that needs to be properly cooked includes aquatic animals such as fish, crabs, and things like snail as well too. It has shown that if, let's take for example, crab. I think there was a study that was done on crabs, because crabs has been shown to be a source of the transmission of the cholera bacteria. It has been shown that if they properly boil, if a corn is cooked for about 8 minutes, the Vibrio cholerae can actually still survive on such crabs. However, if we actually cook and boil these crabs for about 10 minutes, it has been shown to adequately kill off all the bacteria in such crabs. So this just further emphasizes the need to actually for us to properly cook our food well, our fish, our vegetables, and the rest of them. Also, for fruits that usually a lot of people sometimes just buy fruits, cucumbers, apples, and the rest of them, and just not they don't wash them and they just start eating them. This is actually not ideal because such fruits can also be contaminated on the surface by this Vibrio cholerae. So it is important for us to actually wash those our food and our fruit as well before we consume them. And also we also avoid raw undercooked seafood, which I've mentioned earlier. Also, we must use the appropriate ways of the disposal of our feces. And because it is something that usually occur in the rural areas, and where we know that they still use a lot of pit latrines and a lot of people just defecate in open water and the rest of them. We discourage which is something that I know that still happens in some part of Lagos as well too. I've driven along some express which I can't remember the name, somewhere on Lagos Island, and I've seen people actually just sitting on the edge of the bridge with their trousers down and then defecating into the lagoon there. It's something that we, as much as possible. I know the Lagos State government is doing a lot of work on a fight against open defecation, and it simply means that the state recognizes the potential dangers of some of these activities that people do. So as much as possible, our closets are ideal for the for the disposal of our feces. For people who don't have WC, they can actually the water closets. They can use latrines, and also importantly, we must also note this, especially for people here who might know people who are maybe building houses or who encourage or who advises people when they are building houses. I basically just want to mention the siting of the septic pit, the sock away as is usually commonly known for in our homes. Usually there's a public health advice on this that such thing must be at least maybe I think about 30 meters away from our any source of water that we have. So it is not ideal to have a septic a sock away close to where our borehole is as well too, because when the feces get into the sock away, because it's inside the soil, and then some of these things can actually seep through the soil and then contaminate our boreholes as well. And then we also think, oh, yeah, we are drinking or we are consuming safe water in our home, not knowing that the organisms or the dangers of the sockaway or the other harmful things that might be present in the feces or in the sockaway has found a way into the borehole. So we must always encourage people to site their septic pit or their sockaway far away from their from their source of water, especially the boreholes that we drill in our homes. Also, it is important to also note that there's actually a vaccination for cholera. Yes, there are vaccination for cholera, and it is especially advised for people who are traveling to high-risk areas. So when, say, maybe we've heard from different times that different embassies will issue out public health notices to their citizens who are traveling to maybe different countries, whether in terms of war or things like this. So I'm sure say maybe for instance now the US embassy will have issued a public health notice to their citizens that might want to travel to Nigeria to so ensure you get your cholera vaccine before you go to Nigeria, because there's an outbreak of cholera in Nigeria now, especially in Lagos, and then we usually encourage vaccination for such people. However, for us now that we live in these areas, what can we do? We can also get the vaccination. However, the vaccination are not something that are routinely given in our hospitals. It's not part of our NHIS, it's not part of the immunization schedule for children. However, for anybody that wants to get it, they can easily go to any hospital, either private or government, to actually request for this vaccination. I'm not sure how much the cost of the vaccination is, but I know it is not very, very expensive. However, we should also note that the vaccines are not They don't offer a lifetime protection. There are about 3 different vaccines that have been what's it called? Have been encouraged by WHO that have been active against protecting people from cholera. And the names of the vaccines are Dukoral, Eucoplux, and Shancol. I'm not sure if I'm getting the pronunciation of those vaccines right. However, those are the 3 vaccines that have been approved by WHO for vaccination for people. However, such vaccines usually, especially the Uvico Plus and the Shanko, people have to take 2 doses of the vaccine at about maybe 1 or 2 weeks. For one of them is about 2 weeks apart. The other one is about 6 days apart. I think for the Uvico Plus about 2 weeks apart. The Shanko is about 2 weeks. The interval between the first dose and the second dose is about 6 days. So once anybody is able to get their 2 doses of vaccination, they usually are protected from cholera or against cholera for about 3 years. After that, the protection is not foolproof anymore, and they might need to actually renew their vaccination again. For in cases like when there's a local outbreak of cholera like this, it's advised. I mean, it's encouraged that for people who can, they can actually get vaccinated against cholera, especially people who are at risk of cholera. Like I mentioned earlier, children are at risk of cholera. The very elderly people are at risk of cholera. Malnourished children are at risk of cholera. Also, people who are taking maybe medications for maybe things like ulcer, or who have had some form of gastric or stomach surgery to reduce the acidity in their stomach, they are also at risk of cholera. However, that is not to say that every other person is not at risk of cholera. It is a very, very highly infectious bacteria which can actually affect anybody. So for anybody, it is actually encouraged for people to actually get their vaccination. Also, the vaccination is not the only thing. So all the other preventive measures that we've been talking about, we should also, as much as possible, try to adhere to all of those things. So what should I do if there's a cholera outbreak in my community? So let's say, for instance, on my streets, I noticed that there's an uprising in the number, or an increase in the number of people who have been complaining about diarrhea disease, and it might not even be, I might not even know if it's cholera, but because I know that there's an outbreak of cholera in Lagos, I'll be very, very suspicious of cholera. So what do I need to encourage my people or people around me to do? Just to ensure that they have access to safe drinking water, to promote good hygiene and sanitation practices. I know that in Lagos as well, too, we are, especially during the rains, during the heavy rainfalls, especially last week, there were a lot of places that were flooded. And then we know that when such areas are flooded, for people who have this kind of septic pits, the sockways that are not properly covered, they get flooded as well too. And then what happens in that, because it's all the effluent that has been inside these pits comes to the surface, and then they flood into our yards, our compounds, our roads, and all. And these are the things that actually would cause a very significant contamination to all different kind of sources of water, and then also our food as well too. Which is why I mentioned earlier that it's most likely, and then if we've been following the news, we know that the epicenter of the cholera outbreak in Lagos has been documented to be the Lekki area of Lagos, which is also one of the areas that has been well documented to be affected by recent floods in the state. So I'm not saying the flood there has caused it. I'm just saying these are the factors that would encourage the spread of cholera in such areas as well too. Also, we need to help to educate members of our households and our community about cholera prevention and symptoms. But so from the little that we might have learned today, the little we might have picked from this presentation, it is good for each and every one of us to go back to our community, our household, to try and pass some of the messages across to them, and also just for people to be aware about cholera and the things that needs to be done to prevent cholera. And then for people that might have symptoms that might resemble cholera, we need to quickly tell them to visit a health facility for treatment. And when we go to the hospital, it's usually for rapid rehydration and care. And if any members of our household is showing symptoms of cholera, there's no need to be fearful about it. It's something that is easily treated. But what we need to do is that before all of this dehydration gets to the point where it causes a lot of irreversible damage in the body, usually within the first 4 hours, we get the person to the hospital and then ensure that treatment is started for the person. And like I've mentioned earlier, to get vaccinated with the oral cholera vaccine. It's actually it's not an injection. It's something that has to be. It's just like oral polio vaccine. It's something that will be dropped in the mouth. It's something very easy and it's actually very safe. So for people who are at risk, the population who are at risk of cholera, we are all at risk now because there's a local outbreak in our state. So it is encouraged for all of us to, as much as possible, get vaccinated if we can. Let us all remember that safety first. We have to protect our environment, protect ourselves. Let us wash our hands regularly, use our hand sanitizers, properly cook our food, ensure that we consume safe water, and then ensure that our foods are properly and well cooked. Thank you very much for listening.
Thank you very much,
You're welcome.
Dr. Muritala. Very educative, very instructive, very comprehensive and detailed. Thank you very
Thank
much,
you.
sir.
You're welcome.
Yeah, I'm going to go through some things that came out very strongly for me. He did mention that some of the we are used to some of the symptoms, we know about them, but he did mention that it can be asymptomatic. That means you won't show
Won't show
any
any
form
symptom
of
at all. Yes. Symptom.
symptoms,
Yes.
and that person will just be a carrier. So you may
Yes.
think
Person
that
just
there's
gets
no
tired.
cholera in your house, there could be a carrier in the house.
Yes.
So,
Very
and then
possible.
he also mentioned the fact that we can have low blood sugar. He called it
Hypoglycemia.
hypoglycemia. Yes.
Yes.
And then he also mentioned the fact that if dehydration become very severe, it can lead to shock, it can lead to death. There can
Yes.
be seizures in children, and
Yes.
people who have it can go into coma. So these are
Yes.
some of the things we need to know. And then he said for prevention, we should drink safe water. Now, safe water may not be bottled water or
Yes. May not be.
sachet water, because some of those yeah, bottled water and sachet water are packaged in areas that are highly contaminated, so they may not be the safest.
Yes.
He advised that we should boil our
Oil
water,
our,
and
yes.
then he mentioned sighting of our boreholes, that it should not be too close to our septic tanks.
Yes.
So, and then he said we should practice good sanitation and hygiene. He actually emphasized washing of our hands. He said if you don't have soap nearby, we can wash our hands under running water, and then we should use
Yes.
alcohol-based sanitizers.
Yes.
Um, then he also mentioned the cooking of our food, that we should cook our food very well. Then he specifically mentioned vegetables. Some of us don't really cook our vegetables too much, because we believe that the normal thing is that we will lose nutrients. He encouraged that we should wash our vegetables very, very well. And then he also mentioned that even some other food items, that the soil could actually contaminate those foods. So we should wash our food well before cooking. And then he's mentioned some aquatic animals that may be contaminated. I think I've had somebody who ate crab and then got very sick. That is why. So our aquatic animals, we should wash them
No.
well or cook them very well. Fish, snail, crab, and things like that. And then finally he mentioned the vaccination, which is very important. He mentioned the fact that they are not lifelong protection. Maybe it's very active. Within 3 years, we go and renew. And then he also mentioned, this is very important for us retirees, that we should spread the news. I mean, the little we've had on this webinar, let's spread the news in our different communities, so that we can nip the spread of this deadly disease on the board. So thank you very much once again, Dr. Muritala. I know that some of us, we have questions, you know.
Okay.
Please let us come up with those questions so that he will answer for us. Just signify. I will invite you to unmute and then ask your question. Thank you very much. Please feel free, questions, contributions, maybe you want to share an experience, you know. Yeah, I saw a very interesting, I think, let me read it out. Somebody said, fantastic presentation, sir. Water has been identified as one of the major sources of contact. It is worrisome to hear that Lagos State has the epic occurrence as of now. Has hope totally been lost in getting treated tap water in Lagos? Most of this sachet and bottled water consumed in Lagos are produced from points where they are polluted by sewage and other toxic effluents. You know, let this high-powered body submit an appeal communique to Mr. Governor. I think that is very, very instructive.
Yeah, you
That's
said.
very important. We will do
Mhm.
something about that. And
Yes.
then I also want to mention, open defecation is not encouraged in Lagos State. Those of us who are, I know some serving officers are on this call. Those of us who are within that, is our responsibility to enforce some of these laws and regulations. Please, let's get serious about it, because if it becomes an epidemic, everybody is going to be affected. Everybody will be affected. So I'm still waiting for us. You have a comment, you have contribution, you have a question, please, let's come up with it. Let's signify, make use of the emoji, to raise up your hand. Then I will ask you to unmute and then you can ask your question. Okay, let me look through the chat so that we have responses. Okay, I'm going to call Mr. Ashimi. We want to hear your voice, sir. Please unmute and make a comment.
Good morning, everybody. Good afternoon, everybody.
Good afternoon, sir.
It's been a pleasure to be. Okay, let me just on the video.
Okay, thank you,
Pleasure
sir.
to be on this program today, and the topic that you have chosen today is a very germane one. It's very apt and it's very current, and I believe all of us have listened to the very well prepared lecture, and I commend the lecturer for a good delivery of that lecture. I
Thank you, sir.
believe so many useful tips have been given to us, and we should, as much as possible, try as much as possible to spread the word around, because not so many people are on this are listening. So that much I just want to commend the public service office and the office of the head of service for organizing this lecture series. Been very useful. Most of the time I've been missing them, not because of because maybe I had to go out and do some other things, and but anytime that I'm around, I always try to join the discussion, and they've been very useful and very, very well prepared lectures. So I commend the PSO and the Office of Data Service for a job well done. Thank you.
Thank you very much, sir.
Thank you, sir.
So let me also invite someone else, Engineer Adeniyi Abdul. Please unmute, sir. Let's hear your voice. Put on your video. Let's hear your comment or your take on this. Are you there, sir? Engineer Abdul, sir. Please unmute. Okay. Okay. Maybe let's try someone else. Um. Okay. Mrs. Akin Taylor. Please unmute. Let's hear your take.
Good afternoon, ladies
Good
and
afternoon,
gentlemen. I seldom come on, but today, for whatever reason, I chose to come on, and I was very much impressed by the speaker's job, which is very well done. I happen to be a microbiologist myself, so maybe that was what got me interested, that I came on today. And I had thought I would ask 2 questions, but I went to the chat box and I saw somebody had written something there. So that was why I didn't talk in the first instance. And I was going to ask about potable water in Lagos, because I think Lagos being, a first in virtually everything in Nigeria, we should do something serious about that potable water, because that is why people would go drinking pure water all over the place and throwing the nylon bags all over the place. It has become a serious menace for us. And that same pure water is what they used to mix this kunu and all that other people are also drinking. It hasn't come to me. I don't take such, but some people do. And you can't blame them. With a little bit of money they have, they also want some nutrients and all that. And I know that that drink that caused it is very good. So people to also want it. I think Lagos State can look into that. I want to appreciate your office, Ma, for what you are doing. I think you are doing very well. I'm just following from afar, and I am impressed. And the person you called that did not answer you is probably dozed off, because we are retirees and we're at home and it's raining. So you can imagine what we are doing. That's why I didn't put on my video, because I'm actually lying down. Thank you very much.
So thank you very much. I think the PS is not able to join. Maybe she's still in a meeting. Let's have final comments from Mrs. Adekoyi. Please unmute, ma. Mrs. Adekoyi. Final comment is Adekoyi, and then appreciate the facilitator for a job well done.
Oh, sorry, Mrs. Dredola.
Okay, ma.
I want to move away from the phone.
Okay.
Although I didn't join from the beginning, this has been a very enlightening time out with Dr. Muritala. We know that we all think we know everything about cholera, but this has really opened our eyes to see all the intricacies in it and how to prepare ourselves and manage a prevention instead of getting it and now treating it. Because we should not say because we are in the urban areas, we cannot be affected. No, we should just be attentive, look out, and make sure it ends spread more than how it is now. On this note, I want to thank the doctor very much. He's one of our very brilliant doctors at the staff clinic. He's been doing a great work, and I want to wish him well. And I want to also greet all my senior colleagues and my colleagues on the call here. And thank you, Post Service, for the great job that you do.
Yeah, me,
Thank you very much.
So thank you very much. So on
All
that
right.
note, we have come to the end of today's webinar. I want to specially appreciate Mr. Governor and his deputy for always giving us the approval and the necessary fund to keep on running this program. I also thank the head of service and the permanent secretary for their guidance all the time. And for us retirees and serving officers on this call, I'm very grateful. It is because you keep coming back. That is why we are still able to keep on running this program. Thank you very much. God bless you all. I'm going to change the setting now to enable us, as we usually do, to interact and connect with one another. I can see that most of us, I don't know, maybe just like someone said, it's raining, so a lot of us are on the bed. Some have even dozed off. But let's put on, for those of us who are still awake and listening to me, let's put on our videos and exchange pleasantries, because I see that a lot of us, our videos are off. We are not even seeing faces. Let's interact. Mr.
Hello, thank you
Akintola,
very much.
yes, sir.
Thank you very much.
God
I
bless you, sir.
appreciate
Thank you, sir.
the program, very educative and interactive. Thank you very much for
Thank you,
inviting
sir.
me. It's a pleasure.
Thank you, sir. Mr. Amodu, Mrs. Amodu. Mo ń kí yín, ẹ on mute, mo ti change setting.
Thank you,
Ẹ
Mrs.
káàárọ̀
Junoja.
Mrs. Adelaja.
God bless
Everybody.
Amen.
We do enjoy the lectures.
Thank you, ma. Our powerful doctor, Dr. Alao. Mr. Unsu.
Ma,
Mo
good
kí
afternoon,
yín
ma.
o.
Good
Mo kí
afternoon,
yín
ma.
o. Ẹ ṣí fídíò yín lẹ̀ lénìí, a rí yín o.
Thank you for the session, ma.
God bless you. Mr.
Amen.
Ajetumobi, nice having you on the call. Mo kí yín o, Mrs. Ayọ̀délé.
Yes,
Ẹ jẹ́ ká sọ̀rọ̀, ṣó òtútù mú wa ni? Ẹ jẹ́ ká mu, ẹ jẹ́ á mu tíì o. Ẹ jẹ́ ká lọ mu tíì o. So I'm going to end the meeting now until the next 2 weeks. We are going to be looking at another interesting topic around our finance and business. Thank you all for joining. God bless us all. Bye-bye.
Bye.
Bye.
Bye.